Thank you so much for everybody. Elliot Froman, sitting next to my better 7/8, Teresa Froman. This is our fourth, I believe that's correct, our fourth second Tuesday of the month for the National Multiple Sclerosis Society Difficult Case Conference webinars, set up by Doris and by Kathleen, members of the National MS Society, and then working with Teresa and I and the highly expanded faculty that we've brought on in the last 3 to 6 months or so. So great group of people. And then today we are delighted, as in the preceding 3 webinars, we're going to have presentation by an MS Society funded fellow, this time coming to us from the University of Cincinnati, and that is Ahmed Obidat. And this is going to be a very, very good, interesting presentation that I think affects really the transition between diagnosis and therapeutics. As we all know, if you have garbage in, you have garbage out. So I also like the fact that Ahmed presented and transmitted this PowerPoint with lots of interesting information, but without the punchlines. And I think that is to be preferred, I believe, in terms of having folks on and already know the final outcome. I think not knowing that final outcome will be germane to having productive and interesting and hopefully entertaining interaction. So without further ado, we'll move, with one exception that I have to mention, is that we, Kathy, Doris, Teresa, and I, and others are still in communications with neurology N2, neuroimmunology, neuroinflammation, about the prospects of placing the proceedings of the National MS Society Difficult Case Conference webinars, and this will give us that opportunity we've talked about from the inception, which is to have the presenting fellows work with a limited set of mentors and faculty members to help inform them on the writing of not just a case report, but a case report which is really going to be structured in the style and tradition of classic clinical pathological case conferences. Except in our case, we've called them clinical pathophysiologic case conferences, because it argues that we'll probably have much more in the way of structure and function assessments, which are non-invasive, versus going to pathological diagnosis through biopsy, although that will happen on occasion as well. So with setting that stage, and hopefully being able to give everybody on the line a final disposition of those publications at our next meeting in January, we'll go ahead and turn the presentation over to Ahmed. Remember the rules of engagement. We don't want to derail this, but we clearly want to leave it open to punctuate his presentation with questions, concerns, maybe short commentary. And very key is to get as many people participating as possible. So Bob Lissack, God willing, he'll be on, and myself and Tree, we're primarily wanting to serve as facilitators, even though we also can contribute to questions and commentary. So with that being said, thank you so much for everybody coming, and I'll turn it over to Ahmed Obidat from the University of Cincinnati. Thanks, Ahmed.
Thank you very much, Dr. Froman. So I'm gonna be talking about our case today. So hi everyone, my name is Ahmed Obidat. I should probably turn my camera on, although just here we go. So you guys see me?
Actually, you and I look like twins in a way.
Perfect, exactly. Yeah, here we go. And I'm gonna share my slides. I'm just gonna make them to the, this way. Okay, and then I'm gonna move this thing here out of the way, and then we should be good. Okay, so this will be a little bit of an, you guys, everyone hear me? Okay?
Yes.
Okay, so this would be a little bit of a different approach, where I thought of maybe presenting a case where diagnosis, might not be as much as challenging, but is really important to know. But then the management is something that we also really need to discuss and talk about. So it's a toilsome diagnosis and a management dilemma, actually, here. And this is a very recent case that we've had at our center. So we start about who's the patient. So she's a 31-year-old Caucasian lady who has a diagnosis of multiple sclerosis that had been diagnosed in 2007. and it's been followed out in the actually practice in Cincinnati. And she presented initially with left-sided weakness, numbness, and imbalance. That was her first symptoms. Was started on interferon beta, stayed on that for about 3 years, but during which she had a lot of breakthrough disease. So she was not really well controlled on interferon beta. So this prompted the treating physician to switch to natalizumab at the time in 2011. So since then,
Ahmed, for one moment, can you just specify, was she on weekly beta 1A, or was she on 3 times per week, either beta seron or with Rebif?
I think she was on Avonex first and then Rebif.
Okay, so she went from once a week to 3 times a week. Okay, thank you.
Yes, and then switched to natalizumab in 2011, and been actually clinically and radiographically controlled and stable until 2017, when we actually got to meet her. So at that time, she already has had 96 infusions of natalizumab. She is a very active person, so she would run marathons. She would run actually it's called a 100K or something like that. She's a very, very active person, really healthy young adult, doing great.
And one other question, just for all of the listeners here, is we're talking about Tysabri at every 4-week conventional dosing, or did she move to extended dosing? And of course, that will be, those questions are germane to the other question is, what was her JCV IgG status, which you tell us, but just at the front end, were all 96 of the infusions 4 weeks apart?
Yes, they were 28 days apart, so just the regular dosing.
Okay.
She's been taking them. She has not missed any single dose of them, so she was very, very compliant and adherent patient. Her JC virus index will be interesting because she was actually positive, and with the index of 1.34, this when the index came into play. But initially she was just positive, and and the treating physician knew that. And then she was 1.34, and then she switched to 2.36. That was her last index at the time of presentation. So that was
Ahmed, so just again to clarify, when she was started on Tysabri, the treating physicians knew that she was JCV IgG positive at the time of treatment inception.
Correct, and she was positive, and at the time in 2011, there were very limited options of medications.
No, yes, of course, I understand. I'm just asking.
Yeah, and they proceeded with natalizumab. Now, the treating physician was telling her to kind of consider switching to something else for about, I think, twice mentioned in the notes when we reviewed them. And the patient elected to kind of stay on the medication because it's doing really great. Unfortunately, there was not much push to change the medication into something else.
And no discussion in the notes that you recall about, gee, you're positive, it's a great medicine, you're doing well, but based on your serologic status, perhaps one consider more delayed dosing, which is being done by a number of people around the world, maybe 7 or 8 weeks. But you didn't see that in the notes, that there was any discussion.
There was no consideration of the delayed dosing or any kind of every other month. There was consideration of switching to another therapy.
Just stay or go. Okay.
Yes. Okay. This is some of her MS lesions that she got the diagnosis for. So these are just classical, lesions, periventricular. You can see the corpus callosal kind of lesions. So just to say that she does have MS, and it was actually a clear diagnosis at the time. So it was a most likely diagnosis. So what happened? So in early July of 2017, she had these 2 weeks of vertigo imbalance, and that was very similar to her initial MS presentation. So very similar to her first presentation in 2007. So was evaluated by her neurologist. The imaging was obtained, of course, and there was a report of a small non-enhancing signal alteration in the left cerebellar peduncle, which explains some of her symptoms. Vertigo imbalance, that's a cerebellar kind of syndrome. So there was presumed to be an MS exacerbation, was treated with IV Soludomidrol for 3 days, and there was 1 week of prednisone taper that we were able also to kind of see that was given to her.
Beautiful presentation thus far. So I would ask, one question before we continue, and that is a very important practical value. You have somebody who's had to earn their remission, which they did. Tried a few agents previously, went on to Tysabri, went through a period of remission. And so, nothing is a panacea, as you know, Ahmed, and we see evidence of new disease activity. The question then would be, what would be your sequence of diagnostic considerations in terms of where she is right now at the time of what appears to be a change, an interval change in new activity? So my list generally goes from that which will kill you, and always want to never forget that, to the other pragmatic, just as likely consideration. So for you, what would be the list of why we're seeing vertigo, imbalance, and other manifestations in July of 2017?
Yeah, so it is certainly, consideration of someone who has MS that could have an MS exacerbation is certainly a consideration. However, looking back to her history, 6-7 years of no disease activity. So basically, she was neither three on this. Like, she was no evidence of disease activity, not by MRI, not clinically, and now is presenting to us with something that was really highly symptomatic. And she is known to have a high JC virus index, and she is known to have 96 infusions of natalizumab. I would think of PML as something on top of the list to make sure we
the components for, I think, a lot of us, irrespective of what we may be more or less likely. I would think PML would go to the top of the list, because in this context, even in other contexts, can't afford to miss that, and there are things to be done. So maybe we could agree, unless there are dissenters, that there's a sequence of diagnostic considerations for her. One, is this PML? Number two, the drug's not perfect. Could it be breakthrough disease? Yeah. It happens. Number three, just for the purpose of time, could it be that there's an adherence problem? But you and I know, in contrast to tablets that patients must swallow or shots they must inject, in this case, it's pretty easy to find out adherence. Did they come to the clinic? Did they get the infusions? So adherence has to be considered, but lower on the list. Another facet or consideration might be, very importantly, is this a different disease? Is this somebody who has MS but could have had an ischemic or some other process? And then very importantly, as my wife would tell you, is that from the phase 3 studies, we learned that antibodies to Tysabri tend to come up between 12 and 24 weeks, not months, and then very rarely thereafter. However, I mentioned my wife because we have been getting the quarterly draws for the JCV IgG, and we generally will do antibodies against Tysabri either when suspicious or at least yearly. And she's discovered about a dozen patients who have been negative Tysabri antibodies, but in some cases as late as 18, 24 months or later have seroconverted. And everybody on the phone, I hope, will know that if you have a persistent antibody against Tysabri right from the pivotal trials, then you begin clinically and radiographically to look just like placebo. So just quickly to get off it, PML, is it breakthrough? Could we have adherence issues, another diagnosis, or is this really potentially issue of a late bloomer antibody against Tysabri itself? So, okay, let's keep going.
Okay, so that was in early July, and she has not yet presented to us. So she came to us in August 2017 and actually came to the emergency department. And because symptoms really progressed despite the treatment of salmeterol and the prednisone, she now is falling. She's having severe dysarthria. She's having also some swallowing difficulty, left-sided weakness and numbness. She's basically unable to function, even take care of her daily functions. So she came to our ER, and at that time we evaluated her and we've seen her. And she was very toxic appearing when we saw her first. Slow to respond. She had a headache. She had nausea. She was intermittently vomiting. She had vertical horizontal nystagmus. When we examined her eye movement, she had saccadic interruption, and she sometimes cannot even follow and look to the right or to the left. She had a lot of spastic dysarthria, scanning speech. We were able to understand about 2/3 of what she was saying, but sometimes we have to ask her to repeat and repeat. So she looked to us very, very much as a cerebellar brainstem syndrome, so dysmetria. She was left greater than right. She had wide base gait, and actually you need two people to hold her to be able to stand, not even to take a few steps. So it was.
Let me just interrupt for 1 second. not that these are our cousins, but it was a few years ago that my wife was in the clinic with one of our patients who had a predominant constellation of cerebellar and brainstem features, by the way, which she had had for years. And it was time for that patient to see Teresa. We alternate visits. And the conspicuous presentation, or at least declaration on the part of the patient was, you know, Teresa, I have a lot of my same symptoms you're asking about, but the ones related to my speech, my balance, my eye movements have been markedly worse in the last 3 months, not explained by a urine infection, which could be silent, you look. In the end, Teresa brought her out of the room, down the hall, 2 rooms to me, sat down. We went through the same thinking, what would kill our patient we can't afford to miss? And, you know, by the way, this is a patient who's on, you know, intensive therapy. And what we decided was, let's never miss a different disorder. And it was because of Teresa bringing her down the hall and having this discussion where we said, gee, could be antibodies against Tysabri, could be PML, could be breakthrough, could be a different disease. And it was the next morning that Teresa makes the diagnosis of a early stage intraductal carcinoma of the breast with cells on Indian file along the ducts, non-metastatic. And she was then treated, and her neurologic manifestations reverted to her baseline, still there, but the severity from the preceding months were gone. So a nice example of how some dogs have fleas, some dogs have ticks, and some dogs have ticks and fleas. And this clearly was fleas you didn't want to miss, and it wasn't. She had a paraneoplastic cerebellar degeneration with a, by the way, with a positive antibody. In this case, it was YO, not the RI, which you might see with breast and with opsoclonus. So I'll let you keep going because it just sounds very reminiscent. By the way, any other comments from the faculty mentors on the phone? Any other points of view?
There is a question on the chat, and it's from Andrew, and he wants to know if the patient was treated with steroids prior to the worsening.
Yes, she was. She was treated in early July, and then she worsened more in August. So yes, she had the steroids, and she had a week of taper of prednisone. And actually, interestingly enough, she was dosed with Tysabri also. So it was due for her dose. So she was dosed with Tysabri.
Okay. Okay, excellent. Keep going.
Okay. So we talk about localization. Really not here in this case, it's very much pointing toward the cerebellar and cerebellar projections. And we know from the initial MRI, and also the syndrome itself is more of a posterior brain kind of brainstem cerebellar syndrome. And it's having all the features of that syndrome. So as a differential diagnosis, and we just alluded to this, and we talked about this, talk about MS exacerbation, infectious, other demyelinating process, or vascular process, or a peripheral etiology, very much less likely. So toxic also, but I don't know if there's anything. No, there was no really history of toxic involvement or anything like that in the history. So that's her MRI here that we have. Thank you. And yes.
I have another question on the chat. When was the JCV titer last checked?
Yes, it was actually last check in July, and it was 2.39.
Yeah, always when asking if you guys would just, I know who these people are by voice and face, but just identify yourself so Ahmed knows who you are and where you're coming from. That would be great. Okay, so keep going. And by the way, these are the, I would imagine they look like flare on top and a T2 weighted on the bottom. Did we have a T1 axial with gadolinium?
Yep. And in this particular one, I actually didn't put it in this slide. The next one will have it. But this is in August 1st. That's the initial MRI we obtained. And there was no gadolinium enhancement in this particular one. There was some flare hyperintensity, and you can see in the left cerebellar peduncle and extending into the brainstem, and there is some in the right cerebellar peduncle also. And there was that T2. I put the T2 here because there is a message from this T2, not only the flare. The punctate appearance of these leads is very important.
Yes, because the extremely small punctate and multifocal distribution at least raises the specter, the reminiscence of clippers, as well as other things, which is why we asked for the GAD. And sometimes you can have these punctate sort of small Christmas tree lights that can be intravascular lymphoma, but clippers would be on the list. And you see this high predilection for brainstem, which raises the specter actually of a number of things, some more common in men versus women, but we'll get there.
Yeah, so that's the August 1st initial MRI, and I'm just zooming in here to look at this punctate appearance on T2 weighted imaging, and you guys can see how extensive it was initially when she came to us, and that kind of correlates also with her clinical syndrome.
Yes.
So next we did the CSF analysis, and this was in early August when she came to us, so we tapped her basically when she came. And we wanted to know, because what's going on? Is this infection? Is this, PML wasn't something on the top of our list. So there was not much inflammatory kind of markers in the CSF. And you can see how, the TAP results were kind of really within normal limits. Even glucose was also within normal, which we would expect to be affected in viral infection. But
I know we have Veronica Penyak on the phone from, if I'm correct, the University of Chicago, who, I don't know if you were on the line when she presented her beautiful patient who had actually had the Klippers syndrome. But just to ask Veronica, you're thinking about this patient versus yours. Are there a few pearls or pitfalls that you think may be similar, but also sort of strikingly differentiate what you had versus what Ahmed is showing us? Or are they principally?
I think that this patient seems to have gotten worse a little bit quicker than our patient, maybe a little bit more acute of a presentation, although I know PML and Klippers are both kind of more subacute than acute. Another thing is, I mean, the history of being on Tysabri and the JC virus titer is obviously leads you in one direction versus my patient who didn't have a history of MS and doesn't have wasn't immunocompromised in any way.
And I'm going to let this keep going, but I brought it up previously. I'll do it again. When you presented your beautiful presentation, Veronica, I had mentioned the patient that I have who's had longstanding MS and had lost hearing on Gilenya. We went through a whole series of things. And this patient ended up developing PML, but her radiographs and the axial without and with gadolinium is virtually indistinguishable from the Klippers presentation that you presented, Veronica. And then we have some elements that are reminiscent in Ahmed's case here. So even though these would be written up as their stand on their own, I think we now have a bit of a case series of 3 based on punctate, a constellation of those. I think in our patient, it was Iris, which had the presentation of Klippers with very steroid sensitive lesions. And it was, by the way, she's back to work and doing what she does. And then, of course, what you presented. So it's funny how some of these are coming together and have differences, but also they have some legacy value, common ground that I think when I contact the two of you and others who will participate in that writing, I think you'll look at these and say, oh, gee, these really can be quite close. And that's where the really good history taker, like the two of you, and a patient who's capable of giving it to you, and further assessments will help differentiate, which I can tell you in the peduncles and the pons can look almost indistinguishable across these 3 patients. And yours was Klippers, mine was PML with a Klippers like Iris, which went away with anti-inflammatory therapy. And then we have Ahmed's